Okay, guys, chapter 53, introduction to the respiratory system. Key terms, make sure you guys highlight this or put a star next to it, whatever, but these key terms you absolutely need to know. Alveoli, remember that's where our oxygen, gas, carbon dioxide takes place, exchange. Asthma. Atelectasis, COPD, cystic fibrosis, I put a star next to it, NCLEX, NCLEX does ask about cystic fibrosis, larynx, pneumonia, infection in the lung, you need to know that, pneumothorax, seasonal rhinitis, sinusitis, surfactant, I put a star next to it, NCLEX, and you're going to see this again when you get to maternity. Can I turn the page?
Mm-hmm. Sorry, what was the very last one?
Surfactant. All right. Page 930, upper respiratory tract. So this should be review for you. You all did A&P already. The upper respiratory tract is primarily involved in the movement of air in and out of the body. That's what's called ventilation. Oxygen moves more efficiently when, look at this guys, warm and humid, making respiration easier. So you breathe better when that air is warm and it's humid. Humid, there's moisture in the air. The epithelial lining contains goblet cells that produce mucus. Why do we care about that? Mucus traps dust, microorganisms, pollen, and other foreign substances. The epithelial cells of the lining also contain cilia. Remember those little hair-like thingamabobs, right? Cilia, microscopic hair-like projections, there we go, projections of the cell membrane. They're constantly moving and directing the mucus and any trapped substances down towards the throat. That's your upper respiratory tract. Let's take a look at lower respiratory tract. The lower respiratory tract, your respiratory airways, this is composed of the bronchial tree, the smallest bronchioles, and the alveoli. Again, remember the alveoli, this is where gas exchange takes place. Let's talk about gas exchange. Gas exchange occurs in the alveoli. In this process, carbon dioxide is lost from the blood and oxygen is transferred to the blood. The exchange of gases at the alveolar level is called respiration. So do not confuse ventilation with respiration. Ventilation is simply the movement of air going in and out. Okay? Surfactant. Surfactant, guys, is what allows the lungs to be able to expand. Absence of surfactant leads to alveolar collapse. Well, if the alveoli collapses, will gas exchange take place? No. So guess what builds up in the body? Take a guess. What's that? Carbon dioxide, yes, CO2, very good. And on the side I put OB and Peds. You'll see a lot about this when you get to OB and Peds. All right, ventilation. Ventilation, the act of breathing to allow gas exchange, is controlled by the CNS. Your brain actually tells your lungs to go ahead and breathe. The inspiratory muscles, diaphragm, external intercostals, and abdominal muscles are stimulated to contract by the respiratory center in the medulla. Where's the medulla located? In your brain. Key points. The respiratory system has two parts, the upper respiratory tract, that includes the nose, pharynx, larynx, and trachea. The lower respiratory tract includes the bronchial tree and alveoli. Gas exchange occurs where? Alveoli, very good. And the medulla, which is in the brain, controls ventilation. All right, let's talk about upper respiratory tract conditions. We're going to start with the common cold. By the way, the common cold, is that bacterial or is it viral? Okay, good. A number of viruses cause the common cold. These viruses invade the tissue of the upper respiratory tract, initiating the release of histamine and prostaglandins and causes an inflammatory response. As a result of the inflammatory response, the mucous membranes become engorged with blood, the tissues swell, the goblet cells increase in production. The effects cause the person with the common cold to complain of sinus pain, nasal congestion, runny nose, sneezing, watery eyes, scratchy throat, and headache. Those are your signs and symptoms of the cold. Seasonal rhinitis, that's inflammation of the nasal cavity. Sometimes it's called hay fever. This condition occurs when the upper airways respond to a specific antigen, such as pollen, mold, dust. Patient will complain of nasal congestion, sneezing, stuffiness, watery eyes. Next, sinusitis. Sinusitis, that's, the runny nose. The sinus cavities become inflamed. Swelling often causes severe pain due to pressure against, did I say sinusitis? I was thinking of rhinitis. I'm lying to you. Rhinitis is the runny nose, not sinusitis. Sinusitis is inflammation of the sinus passages. My apologies. So with sinusitis, the sinus cavities become inflamed. Their swelling often causes severe pain due to pressure against the bone. Remember, guys, sinuses, those are like hollow areas, okay? So what happens is fluid, mucus, anything that moves, like fluid, if it just sits there, what happens? Bacteria can start to grow, and so the patient can get an infection. Because remember, if it's like sinus cavity, that area is, I'm trying to think of the word I'm looking for. What's that word when something's not concave, but yes, the shape is concave, but it'll come to me what I'm looking for. But anyway, so the patient can have pressure against the bone, which cannot stretch. You guys know that, leading to blockage of the sinus passage. So the fluid there is not moving. It's not being released. The danger of a sinus infection, look at this, is that if it is left untreated, microorganisms can travel up the sinus passage and into the brain tissue. Pharyngitis and laryngitis. These are infections of, obviously, the pharynx and larynx respectively. And we often see this with influenza, and it doesn't matter. It could be influenza A or B. Atelectasis, I put a sad face next to it. You know it's serious. Atelectasis, this is collapse of the once expanded alveoli. It can occur as a result of outside pressures against the alveoli. For example, if the patient were to have a pulmonary tumor. Pneumothorax, which is air in the pleural space. Patients may experience atelectasis after surgery when the effects of anesthesia, pain, and decreased coughing reflex can lead to decreased tidal volume and accumulations of secretions in the lower airways. Let me stop right there. That is why it is so important after surgery that that patient turn, cough, and do what? Deep breathe. The reason we want them to deep breathe, we want those lungs to expand. Because after a patient has surgery, what do they want to do? They want to stay in bed. They don't want to do anything. They don't want to move. But we know if we don't get them out of bed and we don't get them moving, number one, we don't get circulation to those lower extremities. We're dealing with DVT. That thrombus might travel to the lungs and turn into a pulmonary embolism, right? We need them moving and deep breathing because we need those lungs to expand because they're at high risk for pneumonia. Thank you. Treatment may involve clearing the airways, delivering oxygen, and assisting ventilation. It's always easier to prevent than to treat. So make sure that any patient who is at risk for a lung infection, you always want them doing deep breathing exercises. That's the rule of thumb. In case of pneumothorax, treatment also involves insertion of a chest tube. For test purposes, if you ever see on a test, on a question, that the patient had a pneumothorax, automatically, if you see pneumothorax, your brain needs to say chest tube. If they have a pneumothorax, they're going to get a chest tube. And I put NCLEX next to it. NCLEX expects you to know that. So you get a patient that had an MVA, they came in with a pneumothorax. What are you expecting? Chest tube insertion. Pneumonia. This is inflammation of the lungs caused by bacterial or viral invasion of tissue or by aspiration of foreign substances into the lower respiratory tract. So that inflammation in pneumonia, that inflammation that the patient has, usually it's due to a bacteria or a viral infection. But if that patient aspirated and some vomitus got into the lungs, don't you think that's going to cause an infection? Is there supposed to be vomitus in the lungs? No. Is there supposed to be foreign object? No. All right, bronchitis. Acute bronchitis occurs when bacteria, viruses, or foreign materials infect the inner layer of the bronchi. Look at this. There is an immediate inflammatory reaction at the site of infection. You're going to see swelling, increased blood flow in that area, and changes in capillary permeability that leads to leakage of proteins in that area. Bronchioectasis is a chronic disease that involves the bronchi and bronchioles. It's characterized by dilation of the bronchial tree and chronic infection and inflammation of bronchial passages. So it keeps happening over and over and over. With chronic inflammation, look at this, guys. With chronic inflammation, the bronchial epithelial cells are replaced by fibrous scar tissue. And guess what? That fibrous scar tissue does not stretch. It does not expand. So every single time that that patient has inflammation, as that tissue tries to heal itself, the lungs actually get worse because it's being replaced by that fibrous scar tissue. Patients with bronchioectasis often have an underlying medical condition that makes them more susceptible to infections. And here are the examples. You guys know when you see examples, those are select all that applies. What are those? Immune suppressions. So if the patient's taking steroids or other immune suppressive drugs, patient has AIDS or other chronic inflammatory conditions. Next.
Does that say zero stretch at the top?
Yes. Because the fibrous tissue doesn't stretch. Next. Obstructive pulmonary diseases. As noted previously, obstructive pulmonary diseases include asthma, cystic fibrosis, COPD, and respiratory distress syndrome. So for COPD, guys, is bronchitis and emphysema. It used to include asthma, but it does not anymore. So if we're talking about COPD, we're talking about bronchitis or emphysema. And because, you know, I'm trying to keep what I teach you in pharm in line with what you guys are learning in med-surg, you guys are going to be seeing this pretty soon. So something to keep in mind, okay? If the patient has bronchitis, they're going to be a blue bloater, their color is going to be blue, okay? And if they have emphysema, they're going to be a pink puffer. Their color is going to be pink. I'll explain to you why later, we'll get to it. But remember, bronchitis, they're going to have the bluish color. Emphysema, they're going to have the pinkish color. Blue bloater or pink puffer. Moving on. Let's talk about asthma. Asthma is hyper constriction of the airway. But here's why asthma is no longer part of COPD. Asthma, for the most part, is reversible. Patient has asthma, they get a SABA, which is a short-acting bronchoagonist. Short-acting, what's IB stand for? It's short-acting. I think today. Yeah, short-acting bronchoagonist. Immediately they get like albuterol, right? And those airways open up again. But with emphysema or bronchitis, it's not reversible. As time goes on, it only gets worse. Asthma, reversible for the most part. COPD, such as bronchitis or emphysema, not reversible. You guys got it? All right. So asthma, this is hyperconstriction of the airway. And that's why patients who have asthma, you can hear them wheezing. That wheezing sound that you hear is air trying to get through that obstructed airway. Asthma is characterized by reversible bronchospasm, inflammation, and hyperactive activity. You better know that, reversible. It's triggered by, this select all that applies on NCLEX, make sure you know it. It's triggered by allergens, non-allergic inhaled irritants, such as powders or whatever, or factors such as exercise and emotions. A patient that is an asthmatic, they come home early and they find their wife in bed with the mechanic, they can have an asthma attack just by them being so angry. The trigger causes an immediate release of histamine, which results in bronchospasm in about 10 minutes. Make sure that you know what triggers asthma. And up here, I just put the reminder for you. When it comes to COPD, it's bronchitis and emphysema. Bronchitis, they're going to be your blue bloaters. The color's blue, and I say bloater because they have that barrel chest. And emphysema, they're going to be your pink puffers. Moving back to asthma, the extreme cases of asthma is called status asthmaticus. When you see status asthmaticus, that is a medical emergency, okay? That is an extreme case of asthma. It's life-threatening bronchospasm. COPD. COPD is a progressive. That means as time goes on, it gets worse. And not completely reversible chronic obstruction of the airways. And is often related to cigarette smoking. So where asthma was triggered by allergens or emotions or exercise, or non-allergic products such as perfumes or powders, when it comes to COPD, emphysema, or bronchitis, the bad guy here is cigarette smoking. It is caused by two related disorders, emphysema and chronic bronchitis. The characteristics of both disorders are often present in a person with COPD. Look at this, you need to know it. COPD is diagnosed with what? Spirometry. It's diagnosed with spirometry, a breathing test that can measure volumes and flow rates of air. We're moving on to cystic fibrosis. Remember earlier when I told you about cystic fibrosis and how that person who has it makes an excessively large amount of mucus everywhere, all the organs, right? So it's just clogging everything. That's what's happening in cystic fibrosis. They have thick mucus that clogs everything. Cystic fibrosis is a hereditary. I don't know why I didn't put a star next to it because you absolutely need to know that. It's a hereditary disease involving the exocrine glands of the respiratory, GI, and reproductive tract. It results in accumulation of copious, that means a whole lot, copious amounts of thick secretions in the lungs. Moving on, respiratory distress syndrome. Respiratory distress syndrome, this causes obstruction at the alveolar level. Remember, this is where gas exchange is taking place. It's frequently seen in premature infants who are delivered before their lungs have fully developed and while surfactant levels are still low. So that makes sense because remember, earlier we learned that surfactant is what allows those lungs to expand. So if the fetus is delivered too early and they haven't made surfactant, those lungs haven't been able to expand, of course that child could be in respiratory distress syndrome. Surfactant is necessary for lowering the surface tension in the alveoli so that they can stay open and allow the flow of gases. If surfactant levels are low, the alveoli does not expand and cannot receive air, leading to decreased gas exchange, low levels of oxygen, and generalized distress throughout the body as the cells don't have enough oxygen to survive. Summary. Hairs that filter the air, goblet cells, mucus production to trap foreign material, cilia move trapped material towards the throat for swallowing. The alveolar sac is where gas exchange takes place. All right, that's your review. Let's start on drugs affecting the respiratory tract. We're on chapter 54. Key terms that you guys need to know. Antihistamines. Remember antihistamines, they block the release of histamines. Histamine is a chemical released during inflammation that increases the secretions and it narrows the airways. Antitussives, they block the cough reflex. Decongestants, they decrease the blood flow to the upper respiratory tract, decreases overproduction of secretion, so makes you not have that stuffy nose. Expectorants, they increase the cough so that the patient can clear the airway. They get all of that mucus and crap, all of it out, all right? Mucolytics, these are drugs that increase or they liquefy the respiratory secretions, make those secretions thinner, okay? And they aid in clearing their airway. And look at how it's worded: mucus, lytic, to break down. Rebound congestion. There are certain meds, and we're going to go over them, but there are certain meds that you take as a decongestant, but if you take it too much, too often, you can have rebound congestion. And so that same med you're taking for a decongestant, that can cause you to be more congested. Okay, so rebound decongestion as effect of a decongestant wears off, patient is a vicious cycle where the patient has congestion. And rhinitis medicamentosa. I pronounce that so horribly, but you guys see that word, okay? Reflex reaction to vasoconstriction caused by decongestants. A rebound vasodilation that often leads to prolonged overuse of decongestants, and it's also called rebound congestion. Right up here, rebound congestion. Okay, drug cards. Here are the meds I need from you guys next week. Your antitussives, that's number 1. Decongestants, number 2. Matter of fact, your antitussives will be number 1. For decongestants, I want you to split it up. Your topical nasal decongestants, these will be my second cards I expect from you. And the oral decongestants will be the third one. 4, nasal decongestants. Number 5, antihistamines. And you can group them all together. I don't need, first generation, second generation. You can just put them all together, okay, for the antihistamines.
You want us to put all the names?
I'll for the drug parts, I'll tell you which ones. There are a lot of. Actually, put all of them. Yes.
Number 2 and number 4. What's your difference? I know there's different drugs under the category, but
Oh, I just noticed that. Topical. I don't know. Wait. Budesonide, yes. Just looking at them, these definitely are more that we give to our asthmatic patients, and you'll see when we get into that. Number 6, expectorants. Number 7, mucolytics. You guys are making off like bandits. You only have 7 drug cards to give me next week.
so should we do nasal decongestant?
Yeah, that's fine. All right, let's get started. Antitussives. Remember the antitussives, that's what prevents the cough, right? Antitussives, these are drugs that suppress the cough reflex. Persistent coughing can be exhausting and can cause muscle strain and further irritation of the respiratory tract. A cough that occurs without the presence of any active disease process, or if it persists after treatment, it may be a symptom of another disease process, and it should be investigated before any medication is given to alleviate it. And a perfect example is lung cancer. Patient has a cough, they're given an antitussive, which should do the job, but that cough is persistent after they've been treated, it's not going away, they need to be assessed further. And so one of the things often that we'll see when it's a condition such as this, lung cancer, persistent cough, okay? Therapeutic actions and indications of the antitussives. They act directly on the medullary cough center of the brain to depress a cough reflex. Other antitussives have a direct effect on the respiratory tract. Tessalon acts as a local anesthetic on the respiratory passages, lungs, and pleura, blocking the effectiveness of the stretch receptors that stimulate the cough reflex. Contraindications and cautions of antitussives.
Wait, would you mind going back?
Contraindications and cautions of the antitussives. Antitussives are contraindicated in patients who need to cough to maintain the airways. Remember maybe about 10 minutes earlier, I gave you that whole spiel about patients who come from surgery. You better make sure, and that's contraindicated, that they turn, cough, deep breathe, right? So they need to cough. We want to make sure that they can cough up any secretions. We want to make sure that we're expanding those airways. So a post-op patient, is it a good idea to give them an antitussive? No. This is where your critical thinking comes in. So a patient just came from surgery and doctor orders an antitussive. Are we just going to give it because they ordered, or are we going to question that order? You better question that order, because we know post-op, one of the biggest things is turn, cough, deep breathe. Turn what? Cough, deep breathe. So post-op patients, those who have undergone abdominal or thoracic surgery to avoid respiratory distress, we are not going to give antitussives to these type of patients. Careful use is recommended for patients with asthma and emphysema, because cough suppression in these patients could lead to an accumulation of secretions and loss of respiratory reserve. So you better be very careful giving antitussives to these type of patients. Anyone that's allergic, has hypersensitivity, has a history of addiction to narcotics. Codeine, hydrocodone, look, they are narcotics and have addiction potential. Well, what do you think they're making these antitussives with? Very minute amounts, but still. Patients who need to drive or be alert should use codeine, hydrocodone, or dextromethorphan with extreme caution, because these drugs can cause sedation and drowsiness. So they shouldn't be operating heavy machinery, including vehicles. These drugs should not be used during pregnancy and lactation. Adverse effects of antitussives. Traditional antitussives have a drying effect. They're also associated with CNS adverse effects such as drowsiness, sedation. Their drying effect can lead to nausea, constipation, and complaints of dry mouth. You are going to assess this patient for any allergy to antitussives. You're going to perform a physical exam on the patient, monitor their vitals, including temperature. We want to make sure they don't have an infection that's developing. Assess their respirations. Listen for adventitious lung sounds. Let me ask you something. When you're listening to lung sounds and it's adventitious, is that good or bad? Bad. Evaluate their orientation and affect. Implementation with rationale. You're going to ensure that the drug is not taken any longer than recommended. So if the drug, if they're given an antitussive for 5 days, 10 days, 10 days, 5 days, 5 days, or 10 days, and it's past that time and that cough is persistent, it hasn't gone away, they need to be assessed further. Maybe what's really going on is bronchitis or something else. You're going to arrange for further medical evaluation for cough that persists or are accompanied by fever, rash, or excessive secretions. Provide other measures to help relieve the cough, such as humidity, cool temperatures, fluids, the use of topical lozenges as appropriate. And those lozenges, we need to make sure they're sugar-free, right? Because we don't want our patient blaming us for diabetes. Provide thorough patient teaching, offer support. Key points. Antitussive drugs suppress the cough reflex by acting centrally to suppress the medullary cough center or locally as an anesthetic to increase secretions and buffer irritation. And on the side here, I put no to the post-op patient because we want them to turn, cough, and deep breathe. All right, decongestants. Are you guys good or you need a 10-minute break? Okay, good. Decongestants. Decongestants, they decrease the overproduction of secretions by causing local vasoconstriction to the upper respiratory tract. So this is how they work. That production of secretions that the patient's having, it decreases those secretions by vasoconstriction of the upper respiratory tract. An adverse effect of decongestion. An adverse effect that accompanies frequent or prolonged use of these drugs is called rebound congestion. Technically, rhinitis medicamentosa. You need to know that. You need to know that an adverse effect of decongestion is rebound congestion, which means them taking that medication is what's making this condition even worse. So let's talk about it. The reflex reaction to vasoconstriction is rebound vasodilation. Remember that constriction is what was decreasing all of these secretions that was happening. But what happens is if that patient is taking that medication too much, or they've taken it for a long time and then it wears off, they'll have rebound vasodilation, and that vasodilation has an opposite effect. Increases those secretion. It often leads to prolonged overuse of decongestants. So you have to teach the patient. This book, I'm not sure if it says 3 days or 5 days. We'll take a look. But whatever the book says, 3 to 5 days, not to take it for more than that. Usually the books say about 3 days, no longer than 3 days. All right, topical decongestants. And on the side, I wrote speed and squeeze. They speed everything up. You see the heart rate go up. You see the blood pressure go up, right? And squeeze, it causes vasoconstriction. Topical nasal decongestants, that constriction, that's how it decreases those secretions. Topical nasal decongestants, they give you the meds. The one I suggest you be most familiar with is this medication, the Afrin.
You say speed up the heart and squeeze the
Speed up like the heart rate, the blood pressure, and causes vasoconstriction. Therapeutic actions and indications. So guys, topical decongestants are sympathomimetics, meaning they imitate the effects of sympathetic nervous system. And you know that S in sympathetic stands for what? Speeding up. It causes vasoconstriction, leading to decreased edema and inflammation of the nasal membranes. They're used to relieve the discomfort of nasal congestion that accompanies the common cold, sinusitis, allergic rhinitis. Up here on table 54.2, make sure you know this medication, the Afrin, for oral decongestants. Make sure you know your oral decongestants, and you know that they decrease nasal congestion. For the topical steroid nasal decongestants, know these meds and what they do. So the beclomethasone, it's usually given for seasonal allergic rhinitis, relieves inflammation. The budesonide we give for seasonal allergic rhinitis. Fluticasone, I put a star next to fluticasone. Make sure you know fluticasone. We often give for seasonal allergic rhinitis. Make sure you know those drugs. Contraindications and cautions. Look at this. Caution should be used when there is any lesion or erosion in the mucous membranes. And it makes sense because guess what? If there's a cut, there's a lesion, there's an erosion, there's an opening. Don't you think that's going to affect the rate of absorption? Of course it is. So be very careful when the patient has any lesion, erosion of the mucous membranes. Caution should also be used in patients with any condition that might be exacerbated by sympathetic activity, because remember, these drugs do what? They squeeze and speed. So here are your examples you better be careful with. The patient that has glaucoma. What's glaucoma? Increased pressure of the eyeball. We try to make it worse? No. Hypertension. Remember, this drug will make that blood pressure go even higher. So does it make sense for us to give this medication to a patient that's hypertensive? Are we trying to throw them into hypertensive crisis? Diabetes, thyroid disease, coronary disease, or prostate problems. We're going to be very, very cautious. All of these conditions that I just gave you are examples that have been seen on NCLEX. Don't say I didn't warn you. Adverse effects. Adverse effects associated with topical decongestants include local stinging and burning, which can occur the first few times that the drug is used. So you have to teach that to the patient. Use for, so your book says 3 to 5 days, it gives you a range. Use for longer than 3 to 5 days can lead to rebound congestion. You need to know that. As a result, patients tend to use more of the drug to decrease the congestion, and then it gets even worse. It's like a horrible cycle. Sympathomimetic effects, increased pulse, increased blood pressure, urinary retention should be monitored because we know that these drugs have those effects. Drug-drug interactions. The use of topical nasal decongestants is contraindicated with concurrent use, so they can't take it at the same time, of cyclopropane or halothane anesthesia because of the serious cardiovascular effects that could occur. Page 944, nursing considerations. You're going to assess them for any allergy if the patient's taking nasal decongestants. We're going to assess them for contraindications such as glaucoma, hypertension, diabetes, thyroid disease, coronary disease, prostate problems. This looks like a beautiful select all that applies to me. Assess them for pregnancy, lactation. We're going to do a physical exam on the patient, assess their skin color, temperature, evaluate orientation and reflexes. You better be taking their vital signs, especially the pulse, the blood pressure, cardiac auscultation. Why? We want to assess the cardiovascular and sympathomimetic effects because we know that the nasal decongestants squeeze and speed. That vasoconstriction by itself increases pulse, increases, heart, blood pressure. Evaluate respirations and adventitious breath sounds. Again, is adventitious good or bad? Bad. Lung sounds are supposed to be clear. We're not supposed to hear any rhonchi. We're not supposed to hear any crackles. We're not supposed to hear any wheezing. You want to perform bladder percussion to monitor for urinary retention, because remember, urinary retention is one of those adverse effects of the drug. That's why we're so careful. We don't want to give it to a patient who has prostate problems. That prostate's already squeezing the neck of the bladder, right? Evaluate nasal mucous membrane to monitor for lesions that could lead to systemic absorption. Remember, the medication is supposed to be absorbed through the mucous membranes, but if the patient has a cut, they have a lesion, they have an erosion, not only does it increase absorption, it can be absorbed how? Systemically instead of locally. Implementation and rationale. Teach a patient the proper administration of the drug use. We're going to go over that in a second. You're going to teach a patient. The patient should be instructed to clear the nasal passages before use, tilt their head back when applying the drops or spray, and to keep the head tilted back a few seconds after administration. You want to make sure it gets nice and good in the mucous membranes. Teach them not to take that medication for longer than 5 days. Remember, our range is 3 to 5, but no more than 5. Otherwise, they can have that rebound congestion that we want to avoid. Teach them safety measures if dizziness occurs, not to operate heavy machinery, fall precautions. Institute other measures to help relieve discomfort or congestion, such as a humidifier, increase fluid intake, because all that fluid will help break down those secretions, thin it up so they won't be as thick. Give them a cool environment. Avoid smoke-filled areas. You're going to do patient teaching. Before we move on to oral decongestants, let's take let's take a look at box 54.2, right here on page 943. Administering nasal medications. It is important to periodically check the nares for any signs of erosion or lesions, which could allow systemic absorption of the drug. How many times have we seen this? You know you're going to get that as a test question. Nasal sprays. You're going to teach the patient to sit upright and press a finger over one nair to close it. Hold the spray bottle upright and place the tip of the bottle about a ½ inch into the open nares. 943. Firmly squeeze the bottle to deliver the drug. On NCLEX, let me show you. If NCLEX asks about this, here is how it's been seen. They have you put it in order. So they give you the steps of the nasal spray, and then with your mouse, you have to drag and drop and put it in order. What do they do first, second, third, fourth? Okay. Nasal aerosol, the patient should be encouraged to keep the head tilted back for a few minutes and reminded not to blow his or her nose for at least how many minutes? 2 minutes. Okay, let's move on to, where were we? Topical nasal steroids? Where?
Oral decongestant, 944.
Oh, thank you. All right, oral decongestants. This should be easy for you. There's only one drug, guys. The only oral decongestant currently available for use is pseudoephedrine. Therapeutic action and indication. Oral decongestants shrink the nasal mucous membranes by stimulating the alpha adrenergic receptors in the nasal mucous membranes. This shrinkage results in a decrease in membrane size, and it promotes drainage of the sinuses and improves airflow. Contraindications and cautions to oral decongestants. Because pseudoephedrine has an adrenergic property, caution should be used in patients with any condition that might be exacerbated by sympathetic activity. So any condition that the patient cannot afford for their blood pressure to go up. They cannot afford for their heart rate, to go up. They cannot afford for them to have that urinary retention. Any condition such as that, here we go again, glaucoma, hypertension, diabetes, thyroid disease, coronary disease, and prostate problems. Adverse effects. Rebound congestion. Because this drug is taken systemically, adverse effects related to the sympathomimetic effects are more likely to occur, including feelings of anxiety, tenseness, restlessness, tremors, hypertension, arrhythmia, sweating, pallor. Have you guys gone over hyperthyroidism yet? No, a little? Okay. These are symptoms you see in the patient where they have excessive function of the thyroid. They have hyperthyroidism. They're like this. They're like this. And they're not stopping. They're like this all day. They're like this all day. They're like this all day. Everything's like this all day. The blood pressure's up. The heart rate's up. Their talking's up. Their thinking's up. The GI tract. That is what you're looking at. That's the type of patient that you're dealing with. Same as here. I bet you guys will never forget hyperthyroidism. Okay? Everything is up and through the roof. This drug is found in many over-the-counter cold and flu preparations, and care must be taken to avoid inadvertent overdose when more than one drug is used. So we got to be very careful. Oh, I'm out of breath. You guys know I'm out of shape. Drug-drug interactions. Many behind-the-counter products, including cold remedies, allergy medications, and flu remedies, may contain pseudoephedrine. Let me stop here. Remember I told you whenever you're studying and you see the author telling you the same thing in a different way, you know it's going to be a test question. Do you think it was just by coincidence that they told us right here, oh, there we go, that this drug is found in many over-the-counter and flu preparations, and so you have to be careful so they don't get an overdose. They said it to us right here in this paragraph, and as soon as we go to drug-drug interactions, the first thing you see is that it's found in many over-the-counter and cold medications. Taking many of these products concurrently, taking many of these products at the same time can cause serious adverse effects. Teach patients to read the labels to avoid inadvertent overdose. Nursing considerations for the patient taking oral decongestants. You're going to assess them for allergy, pregnancy, breastfeeding. And you're going to assess them for contraindications, such as having hypertension, coronary artery disease, hyperthyroidism, diabetes, prostate enlargement. Remember, it can cause urinary retention, so you're going to monitor urinary output. Implementation and rationale. Note that this drug is found in many behind-the-counter products, especially combination cold and allergy preparation. That's why you're going to teach a patient to always check the label, because we do not want them to overdose. Monitor the pulse, blood pressure, and cardiac response to the drug, especially in patients who are at risk for cardiac stimulation. You're going to encourage the patient not to use this drug for longer than a week and to seek medical evaluation if the symptoms persist after that time. I usually give you guys 10 minutes breaks, but I want to cover as much as we can. But let's take a 5-minute break, because I gotta go. Let's take a 5-minute break, and we're going to come back and start with nasal, topical nasal steroid decongestants. Okay, guys, we're on topical nasal steroid decongestants. Something, guys, something you need to keep in mind when it comes to steroids, regardless of the indication of why this patient's getting steroids. 3 things need to be going to your mind whenever you think of steroids. Number 1, sugar. Steroids are sugary, so it increases the patient's glucose, okay? So we have to be watching that blood glucose. 2, steroids mask the signs and symptoms of infection. So this patient, we have to watch much, much more closely for fever, inflammation, those signs and symptoms of infection, okay? And 3 is fractures. Steroids make the bones porous, so it puts the patient at risk for fractures. So any patient that is on steroids, you need to be thinking about those 3 things: sugar, infection, fracture. Got it? All right. Anyway, topical nasal steroid decongestants. They're popular for the treatment of allergic rhinitis. Remember, I told you rhinitis is a runny nose, so having the runny nose from allergies, and to relieve inflammation after the removal of nasal polyps. And remember, I told you steroids mask those signs and symptoms of infection, such as what? Inflammation. So it's great for the patient that has had allergic rhinitis. It decreases inflammation, but we better monitor that patient a lot closer. Pharmacokinetics. You know, whenever I talk about pharmacokinetics, it's important because I usually skip it, right? Pharmacokinetics for steroid decongestants. The onset of action is not immediate. You need to know that. The onset of action is not immediate, and these drugs may actually require up to a week to cause any changes. So that's going to be important to tell the patient, because if they don't know that, they'll just think that the doctors or the nurse practitioner or the PA, whoever, is just a hack. They don't know what they're talking about, and they'll stop taking the medication. So you have to warn them that it can take a week before the medication starts to work. If no effects are seen after 3 weeks, the drug should be discontinued. Contraindications and cautions. Let me stop. Let me back up a little bit. I know we're doing pharm, but I'm also trying my best to teach you guys studying strategies. I want you guys to notice something. Well, I just talked to you about pharmacokinetics, how, it'll take up to a week before it starts to work. And if it doesn't work after 3 weeks, it should be discontinued. Have you seen this with any other drug? No, right? Whenever you're studying and you see something that's different than anything else, don't you think that's going to be a test question? That's what makes it different from all of the other drugs. Just saying. Contraindications and cautions. Because nasal steroids block inflammatory response, their use is contraindicated in the presence of acute infections. And it makes sense. Increased incidence of Candida albicans, that's the fungal infections such as thrush, has been reported with their use related to anti-inflammatory and autoimmune activities associated with steroids. So you're going to be checking them. You're going to be checking them for thrush. You're going to be checking them. They might even get yeast infections. Moving on. Patients using nasal steroids should avoid exposure to any airborne infection, such as chickenpox or measles. As with all drugs, caution should always be used when taking these drugs during pregnancy and lactation. Because systemic absorption of this drug is minimal, they are often used during pregnancy and lactation. Adverse effects. The most common adverse effects: local burning, irritation, stinging, drying of the mucosa, and headache. Nursing considerations for the patient taking topical steroid nasal decongestants. You're going to assess them for any allergy. You're going to make sure that they don't have any active infection going on. Because remember, it's a steroid, which means it has anti-inflammatory properties. You're going to perform an intranasal examination. You're going to make sure they don't have any lesions, any erosion, any cuts. You're going to assess respiration and check for adventition sounds, monitor their temperature. For implementation and rationale, you're going to teach the patient how to administer the drugs properly. You're going to have the patient clear the nasal passages. Look at this, before using the drug. If their nose is full of all this thick, nasty sputum, right? How's that drug going to work? Their nose is clogged with all that thick sputum. So you're going to make sure, did I just say sputum and nobody even corrected me? Secretion. Come on, guys, wake up. I'm talking crazy and nobody even corrects me. Secretion. Their nose is full of that nasty, thick secretion. How's the drug going to be absorbed? So you're going to make sure that they blow their nose. They clear all that nasty secretion out so that when they put the drug in, it works. They have to clear the nasal passages before the drug. Encourage the patient to continue using the drug regularly, even if results are not seen immediately, because we know it can take up to how long? A week. It could take up to a week before it starts working. And if they haven't worked, in how many weeks does it have to be discontinued? By 3 weeks. If it doesn't work, it should be discontinued. Monitor the patient for development of acute infection that would require medical intervention. Encourage the patient to avoid areas where airborne infections, remember, such as chickenpox, measles, could be a problem. Such as, them working at a preschool and they're dealing with a whole bunch of kids that are anti-vaxxers. They got to be careful. They need to avoid even the chance of chickenpox or measles. Key points. Decongestants cause local vasoconstriction. Remember that vasoconstriction is what decreases those secretions. And the opposite, when you have the vasodilation, that's what causes that congestion. Rebound vasodilation, also known as rhinitis medicamentosa, is an adverse effect of excessive long-term decongestant use. That's why we tell them not to use it for more than 3 to 5 days. Topical nasal decongestants are preferred for patients who need to avoid systemic adrenergic effects associated with the oral decongestants. Topical nasal steroid decongestants block the inflammatory response, and they're preferred for patients with allergic rhinitis, but we better be careful. We better make sure they don't have any active infections going on, right? Okay. Take a look at table 54.3. Make sure you know cryphorheptidine. I'm not gonna try to pronounce this drugs. You see Benadryl, Vistaril, Antivert. Make sure that you know. Hold on, there's that clip so you guys can see this. Okay, with the Antivert, relief of nausea and vomiting associated with motion sickness. Meclizine, you guys are going to see this in med search. You have to know this med. Promethazine, that's good for allergic rhinitis, allergic conjunctivitis.
Wait, sorry, we can't really see that.
Cetirizine, the Zyrtec, for seasonal and perennial allergic rhinitis, chronic urticaria. And last, our Claritin, which is loratadine,